Hello, everyone. Welcome. Thank you so much for being here for the second webinar of our Women in Global Health webinar series, which is co-organized by NUS and the University of Malaya. So today's guest is Dr. Joanne Liu. Now I will leave the word to Prof. Shu Liang, the Vice Dean for Global Health at the Saw Swee Hock School of Public Health, who will be introducing our speaker and moderator for today. Thank you, Liang.
Thanks very much, Kapu, and good evening and good morning, everyone. So as Kapu has mentioned, welcome to the second webinar of the Women in Global Health series, which is jointly organized by the National University of Singapore and the University of Malaya. So there will be a total of 4 seminars over the course of a year. So there'll be 2 more coming up after this, which I hope you'll all join us in attending. The session today will be done in a question and answer style with an initial discussion moderated by Professor Natasha Howard, followed by a Q&A where you, the audience, are free to ask the questions. Professor Howard is from my school, the Saw Swee Hock School of Public Health. She's an interdisciplinary health policy and systems researcher that's focused primarily on low and middle income countries. And she engages in policy relevant research in infectious disease control in Asia, as well as strengthening health system responses during protracted adversity. Our distinguished discussant today is Dr. Joanne Liu, who needs no introduction really, but I will introduce you anyway, Dr. Liu. So Dr. Liu has served as the international president of Médecins Sans Frontières from 2013 to 2019. And when she was at the helm at MSF, she has been a leading voice on medical humanitarian crisis, including the Ebola outbreak in West Africa, attacks on hospitals, and the forced displacement crisis. She has also engaged with world leaders at the highest level. Dr. Liu's role builds on a career of fieldwork with the MSF, including over 20 medical humanitarian field assignments. She trained at the McGill University School of Medicine in Montreal and holds a fellowship in pediatric emergency medicine from the New York School of Medicine and an international master's in health leadership, also from McGill University. Dr. Liu's operational work has ranged from introducing comprehensive care for survivors of sexual violence to developing a telemedicine platform for connecting doctors in rural areas with specialists worldwide. Dr. Liu remains a practicing doctor, both in the field with MSF and also through hospital shifts in her hometown in Montreal. She's currently a professor at the School of Population and Global Health at McGill University with a focus on pandemic preparedness, response, and health emergencies. And I'm sure you have a good time listening to her tonight. So over to you, Natasha.
Thank you very much. And Dr. Liu, welcome this evening, and thank you very much for being here. I have several different questions to get through, so we'll just make a start straight away and expand as you see fit on any of these questions, and we will see how we get on for time. All right?
Sure.
Great. So my first question is, given that you have extensive frontline experience in humanitarian medicine and high-level policy, most recently advising on the global response to COVID-19, what are some of the challenges and opportunities to making an impact in both positions, and how do you balance acting through these two, through the front line and through the more high-level policy?
I think it remains a huge challenge, but I think that at ground level, ground zero, it is, I would say to a certain extent, easier to see an impact, because you have people who are living in a crisis, I would say, ecosystem. And then if you have the right program, if it's well integrated with good allyship and partnership, you can make a difference in people's life in terms of living, access to healthcare. So that's, I find, not too hard if you have a good platform to work. And I've been very fortunate because I was with Doctors Without Borders. It's an international organization of more than 1.2 billion euro on a yearly basis, working in 70 countries with a workforce of more than 60,000 people. So we have the infrastructure to be able to deploy quickly and efficiently. So that's I would say that's more or less, to a certain extent, and I don't want to oversimplify things, but a more within reach goal. In terms of policy level, it's very hard because it's a huge machine, and there's a lot of things at stake, power of influence, and from some countries or from some agencies, either from the UN system like WHO, UNHCR, UNICEF, OCHA. So it's all there, and then you have to navigate that in addition of the political agenda of those organizations to the one from the countries, the donor countries, and the country who are affected. So it's not easy, but what I try to do, and I still try to do nowadays, is just that a lot of people who are at the high level policy don't really get a real experience from the ground zero. And when they speak, there's a bit of a disconnect of what they are bringing forward. And so I think the strength of, not for me per se, but for people who are working for organizations who are at ground zero doing real action, I think then when they bring testimony of what's going on to change policy, it is much more anchored in people's reality and in people's needs. So I guess that's what I can say and I would just advise to take that within a grain of salt, because there's a lot of this sort of white savior, I would say, attitude, and then we have to move away from that, and we have to make sure that the people that we are aiming to help are part of the solution. Nobody in any crisis are, I would say, passive victim of a situation. They are an active, I would say, person affected by a crisis.
Sure, absolutely. And thinking in those terms, because there has been a lot of this we've seen in the humanitarian space, as well as development more generally, what do you think that international organizations, particularly humanitarian organizations, since that's largely your background, can do to start shedding this harmful saviorism? And have you seen any positive shifts with this?
I think everybody is trying to address the issue, and I think it's very difficult to a certain extent, because there's something very, very groovy and then adrenaline type of you've got a rush of adrenaline. You go somewhere and you have the feeling that you're making a difference, if not saving someone's life. And so it's you can get easily addicted to that. So how can you have the same, I would say, outcome of people lives being saved, or people life being, I would say, improved, but by making sure that it's within the respect of the dignity of the beneficiaries of the patient, within the respect of the local hierarchy and system where you are bringing your aid, and the fact that you should try to look at it in a way that as that it's not about you, but it's about people you're trying to help. And I always had a bit of a how can I say, a discomfort, if not a malaise, of seeing sometimes agencies or individuals taking pride of what they're doing. There's something that is not right. You cannot take pride when you're working in a situation where people are undergoing so much suffering. So I think you have to be humble, because coming from a humanitarian aid agency that has been performing fairly well for the last 50 years, we're privileged, and we always will be. And even when we come and bring aid, it's a momentary moment. It could be a month to a year, but we're going to go back to the world where we come from. And so it's a completely, I would say, different, I would say, appreciation of things.
Sure, thank you. Taking a slightly different view of things, sometimes you have had to engage with governments, say, for various tasks whose actions you may not condone. For example, Europe's poor response to forced migration over the past few years that we've seen. How do you manage these tensions, working with people or institutions whose actions you don't support in order to provide greater benefits?
Well, I would say there's nuances in things, and there's a level of gravity of things. I think that in terms of Europe, we were quite appalled about the situation in the migration situation in Greece, but as well in the Balkans and more south in Libya. And then one of the things that it was astonishing, the peak was in 2015, where about 1 million people end up showing up on the shore of the beaches of Europe. But the reality, there wasn't a new phenomenon. It was enhanced throughout those years, but this was not a new phenomenon. People have been migrating since the beginning of the history of human being. That is totally linked to the way we are, the way we perceive our chances of survival. We're going to go where we think we're going to have greater chances. So we've been engaging with country, and we've been telling them that it's part of your responsibility, moral responsibility. There's the moral argument, but there's as well the very, I would say, mathematic calculation, which is we know the level of fertility in the global north, and we know that when it's below 2, then you have basically an aging pyramid of age. And so that's going to be very, very hard to project yourself in the future, knowing as well that the older generation is actually surviving much, much longer. So if you don't restore a pyramid of age with a young generation, that's going to be extremely challenging. So, but even those kind of arguments are not really flying. What is interesting, though, Germany did welcome 1 million refugees, mostly from Syria. So it happened. But at one point, you bring them a reality check. And I think what was the most, I would say, distressing, if not shocking, is the fact that there's many crises in the world that we think that we don't have much of a say, because it's hard to talk to the key people involved in the crisis. We have one right now in Eastern Europe, but the thing is, when you know that public money is being used to increase people's suffering by sending them back to Libya in detention center, when we know there are places of, I would say, of no human rights, more or less, and we contribute. That is what is the most, I would say, outraging. And so at that moment, MSF, when there was the EU-Turkey deal, where basically it was at Libya this time, but it was basically sending back, if you were not a regulated migrant, you were sent back to Turkey, and there were a swap between a regulated migrant against 1 or 2 unregulated migrants back to Turkey. And this is when the organization had decided to stop taking European Union funds. And it's not a small thing, because it was something close to 10% of our budget.
Yeah. Thank you. It's really good to get that insight. On a slightly similar topic, I wanted to ask a bit about the issue of attacks on healthcare. So you're known for your response to the US air attack on the MSF hospital in Kunduz in Afghanistan in 2015, and then representing MSF at the UN Security Council debates, following which Resolution 2286 was adopted, which reaffirmed the protected status of health services during conflict. Yet we continue to see attacks on healthcare, including many in Syria, including now in Ukraine. These breach the Geneva Conventions, yet they continue. So realistically, how could this change so leaders would respect these conventions? Is there more that could be done?
There's always more that could be done, but after that, do we have this appetite? The reality is the resolution, there's already the international humanitarian law, which basically the resolution more or less reflected in new wording the core thing of IHL, which is you don't bomb a hospital, you don't bomb medical equipment, you don't bomb doctors, you don't bomb patient. Very, very basic. And this will work if there's not full impunity happening and not let happen. And so therefore, by the idea of the resolution was to get, I would say, a political signal from the community that there were rules of war. That's one thing. But then if you're not ready to enforce them and apply them, and then making sure that the perpetrator are being named and shamed to a certain extent, then very little will happen. The mechanisms is there. You can go in the independent fact-finding commission and find out what happened, and we can find we say the real information of what happened. We did it, for Kunduz. 42 people lost their life over 5 airstrikes in the night of October 3rd, and so 14 of our colleagues died, and we were outraged. But as you rightly said, so it's happening almost on a daily basis. If you look at all the conflicts in the world, what we need to do is we need to have people, and I would this is what I would have wished way back in the past, is to have the medical community across the world saying, wherever you are, being in Singapore or being in Montreal in a teaching hospital, or being in Kunduz in Afghanistan, or being in Ukraine in a Zaporizhia, you don't bomb a hospital. A hospital is a place of healing. You cannot let happen that when someone is struggling for his life, he has to fear that a bomb will fall on their head. That's universal. And the thing is, the more we're going to speak about it, and the more people will put it squarely into the public place, will at the very least avoid complete impunity. But there is as well mechanisms that can happen. But at the moment, the way that the UNG works and the UNSC is we are in, I would say, in a situation of impotence from our multilateral platform.
Yeah, I'm afraid so on that. I think it's something that's going to require so much more dialogue and political will than we've seen so far. Moving on to another topic, since this webinar series is on the topic of women in global health, I want to touch a bit on gender. So as a medical doctor, you specialize in pediatrics and you've done humanitarian work, et cetera, for many, many years. how important do you feel that it is to consider gender issues in humanitarian settings? And what does this look like? What does this consist of to you?
Well, I want, for me, when I was reading the question, I didn't know what you meant, like gender issue for who. You're talking about the people, the beneficiaries and the patient, or you're talking for the worker?
Yeah, and I think this was a little bit unclear for me as well. So I would say to maybe look broadly at, if you were going to take a gender lens, where would you focus? Would you focus on the organization? Would you focus on people on the ground? How would you make a first few steps? What do you think would be the main things that need to potentially change, is how I would interpret that question.
Well, I think that in both regard, things needs to change. So that's the short answer to the question. I think at ground zero level, what it is clear is we know that the protection of women is always at stake, and it's always an issue. And we see it, along the migration route. For example, people who are leaving the Northern Triangle of Central America towards the US. I was there a few years ago, and women were getting what we call shots for how you call that, the protection to not get pregnant, and so because they knew that the deal is sexual abuse will happen along the path, and regardless, you may want to look at it, in so different ways, but the sexual violence toll, although it happens in men, mostly happen in women, and it verified itself in every single circumstances. As soon as women are in a position of vulnerability, it happens. And then if you look at it in history, it's been like in war in the past, it was part as the reward that soldier would get to a certain extent. So I find that we know that, but we still don't do enough, I find, to protect women. We still don't do enough to make sure that they have all, I would say, the aid and access to basic stuff, like that could be treatment of IST, ARVs, and PEP, access to interruption of pregnancy, the morning after pills. It is not readily available, or not as obviously available as it should be. So that's something. The other thing is, I still find, completely astonishing that in the 21st century, you go in refugee camp in Europe. It was like a few years ago. Things may have changed. I'm just saying that with a grain of salt. But I remember going to one of the bathroom in a camp in Greece, and there were always events where women will be intimidated, bullied, and if not, physically or sexually abused. And it was always happening the same time when women would go to the bathroom. And I just said, bloody hell. I said, we know that. We've known that for decades. I said, put spotlight. Why do you put the bathroom at the corner of the camp? Put it in the middle of the camp where the women won't have to be alone, far in a dark corner of the camp. And then she's going to feel safe. Why, and again, this is for me exactly, an incarnation of people who come and do and build those sightseeing, and they just say, well, I would like to go in a very sort of a quiet and isolated places because this is for my private moment. But you coming from a country where it's safe and you can allow to do that, this is not the case here. And so this is when we think about decolonization of aid, it's as well seeing a situation not from your perspective as an outsider, but from the perspective of people who are seeing. And now we're starting to really much more include them in the think through of what they need, instead of saying, I know what you need. You need food, and you need a shelter, and you need access to care. And it probably needs some of that, but it might not be in the same order. It might not be to the same emphasis. And then what we discover with time as well is more and more people prefer to have an amount of money than to have things in goods. And again, it's a very paternalistic way to have decided for decades that we will not give you money, but we give you a bucket, we give you a liter of oil, we give you a 5K of rice, and then you should be happy with that, and maybe a plastic sheeting. So, and so instead of saying, what do you need? And what will make sense for you? And we have evolved over the last 10 years. I'm not saying we haven't evolved, but this needs to be ingrained and should be the foundation of how we architect and how we thought through a project at Ground Zero.
Yeah, no, I would agree, because I think some of the research we've done recently has also shown that these basic issues that we have known about for a long time are still continuing. And again, a lot of that is a sort of cycling of new people coming in and relearning things that were already known, which is a bit of a problem as well. Continuing on this same theme a bit. So in terms of how could we possibly increase women's leadership in humanitarian work, and even thinking more broadly in global health generally? And is that something we want to do?
Well, the thing is you need to have women in place of leadership, top leadership, second level leadership, and they need to be a group of women need to sit at the table. We've seen it, in with AIDS and the response to AIDS in low and middle income country. And then recently in Montreal, we have the AIDS International Conference in July. And if they're not at the table discussing and then feeding, what is the issue and what is their perspective of things, it's again, there's going to be a bias, a double note bias. So people need to be at the table to negotiate and table of decision making, or table of concertation, like we say, table of negotiation, of reflection, needs to be inclusive. And I think everybody is aware about this, but how do you walk the talk? How do you really make sure? And then you don't want tokenism as well. So you want people who are able to bring something at the table. And then the reality is as well I'm seeing it right now is we have people who come in from the activist side, and it's good, but then beyond the activist side is how do you chip in elaborating real solution? Because there's one thing to just say vaccine equity, for example, vaccine equity, but how do you enact vaccine equity when you look at all the stakeholder, and how do you really make it happen, and come with a proposal that, as much as the private or the public, or what some people call the plural sector, the CSO, are being involved.
Mm-hmm. Great, thank you. So I have just time for 2 quick questions before we hand over to the audience. On a very, very different topic, you've been an advocate for telemedicine and co-managed MSF's telemedicine project. So during the COVID pandemic, telemedicine has grown considerably, with people locked down and receiving virtual care. So do you think the COVID pandemic has made permanent changes in the telemedicine landscape in humanitarian settings? And if so, how?
No, I think that we've, all the things I've been selling in like 15, 20 years ago, it's finally, fall into not deaf ear, but for more, receptive ears. So that's great. And I think that I think that it will probably bring some sort of democratization of access to special healthcare. And then the reason why we did it at MSF when we started it in 2009 was the fact that where you're in the middle of nowhere, having someone who was specialist in a specific field giving you their medical advice was great for the patient and for you as well, the treating physician. And but there were like a lot of pushback back then, because our medical department in MSF were feeling that they were being stolen of one of their responsibility. And I remember telling them, but you're not being stolen. I'm not taking something away from you, because people send you questions on internet and you don't answer them. We're just building a network of specialists that will timely answer the field instead of waiting for 1 week. And you know, when you have a patient who's not doing well, a 1 week is a very long time. So I think it's going to be there. Then it's to find out, you know, because there's some challenges in some area. It depends on your bandwidth. You need to have a good enough bandwidth to be able to have movies, for example. If you are doing an ultrasound and you want to show your picture, there needs to be some bandwidth capacity. So we cannot be oblivious about the technical challenge that it may represent, but I think it is there for good. We have tested it in the most, you know, improbable place like Somalia or Syria in MSF, and it really breaks the isolation of the people who are working, and it allows, and this is something that is not that is worth to be mentioned, is when we train as a doctor, anyway, in where I've been trained, it's a very collegial process. You learn and you have colleagues around you and you discuss cases, and all of a sudden you will be sent somewhere on your own. You will need to manage forever on your own. So I think as well, it's to restoring this sort of ecosystem of collegiality around a patient.
Yeah, that makes a lot of sense. And final question, just taking a broader view, given that we have quite a diverse audience here, and you also oversaw a very diverse workforce in terms of people from all different backgrounds, et cetera. How does diversity of background contribute to global health engagement? And what advice would you give people here, somebody who is exploring how they might make the most impact, whether it be frontline or policy work, for instance?
No, I think, you know, anyway, if people are making this choice in the audience, thank you very much. I think that we still need people, but I think what we need in terms of approach and mindset, it's humility. You go in situation of, I would say, utter vulnerability of people, and you may have a lot of diploma, but those people that you're going to pretend to bring help went to the school of life for several years, if not several decades. And then my advice, it would be humility, empathy, and listening to them, because most of the time they do have the answer while you were talking to them. They are telling you what they want.
And thank you very much for that. I will now hand over to Kapu, because you wanted to see if there are any questions from our audience. Once again, thank you very, very much for being here, and I'll hand over now.
Thank you so much
you.
for a very great discussion, and thank you, Prof. Howard, for moderating and asking the questions. So now I'll turn it over to the audience. You can either type your questions in the chat, or you can directly unmute yourself, or just ask on the audio. So if anyone has any questions, please go ahead. Okay, we have a question from Dr. Abhishek Bhatia. So he's asking, humanitarian assistance, in a sense, is transitory and temporary in nature. Does it play a role in helping the health system of the crisis-affected country become more strengthened? And does it add to health security in the long run? How do we make sure that health access in these countries becomes sustainable in the long run?
Yeah, great question. There's different school of thoughts about that. And then over the last few years, there's been the nexus between the humanitarian agenda and the developmental agenda at the UN. And this is something that we at MSF, and I don't know where they are now because I left 2 years ago, but we were very concerned about that because the issue about the nexus of humanitarian aid and developmental aid, people did that because it was, I think, an economy of scale in terms of funds, but it needs a different type of skill set and it needs a different type of mindset. When you are a humanitarian aid worker, for which I have been often criticized, is you come and you respond to the urgent people's need. And then you don't wait to make sure that you're going to have an exit strategy. You don't really, you have people who are dying and just say, let's try to respond to that. Like after an earthquake, someone is under the rubble. You don't want to wait, how sustainable it would be to have a program of getting people out of the rubble. You just rubble, you want the people out because you only have like few days to manage that, a few hours. So there needs to be a distinction about humanitarian assistance. But the thing is because I don't think it needs the same mindset, I don't think it's the same skills. But what probably need to happen is not as much to mix, but to make sure that the humanitarian aid is fostering for strengthening of a system as much as possible. But sometimes you're not in that kind of equation because you initially you are in this very, very acute phase, especially after an earthquake or a flooding or anyway natural disaster. That being said, what we realize is often in many of those countries who are awfully affected, NGOs are there, for decades. And then the question is being asked, how come haven't you invested more in the healthcare system to strengthen it? And so this is where I think there's room for major improvement. And how come you haven't trained, for example, MSF has been in DRC for decades now, Democratic Republic of Congo, and we've been having what we call the PUC, which is Pool d'Urgence, which is the emergency pool for crises and for outbreaks. And then how come through all those years that we haven't basically trained more people to do surveillance, more epidemiologists? We've done few, but we probably could have done much more.
Great, thank you for your answer. So if there's any other questions, please type in the chat or you can raise your hand as well on Zoom. Maybe in the meantime, I'll ask a question of my own since I'm very interested in mental health. So it takes a lot of mental strength and clarity to work in humanitarian assistance, and this can be difficult to maintain in the aftermath of trauma and crisis. So I wanted to ask you, what do you think can be done to support the mental health of humanitarian workers and medical workers to manage their well-being while they need to support others?
Well, this is something that is much more, I would say, recognized nowadays than it used about like just 10 years ago. And I think that in the mid-90s, we started to really have, I would say, recognition of mental health in the beneficiaries and in patient, and we had much more system. And especially I was quite involved in sexual violence, and then we had a comprehensive case management, including mental health support. And then now it's part of the minimal package of where we are. But it's often the under-recognized, I would say, issue. That being said, there's some improvement. If I take, the mission we had, for example, in Libya, where MSF is working in detention center, which is probably one of the most awful place where I've seen human being living. And this is why we speak out about that, and we as MSF has been repeatedly denouncing the detention center in Libya as place of no rights, and they should not exist, not in this kind of setup for sure. People who were working there. I just remember once when I went there in 2017, and then one of the nurses tell me, "You know what, doc?" She was a nurse. She said, "That mission is just fucking my head." Because the stories that we were hearing from people about their journey to try to go somewhere for a better life was atrocious. The suffering, the I would say the violence that they went through repeatedly was awful. And so we had for our patient people in mental health, and we have as well full-time people for our team. And then our team could not stay there for too long because it was too distressing. And even me, who was there only for few few days, was badly impacted by seeing so much, I would say, obscene and undignifying violence toward people and human beings. Yes.
Yeah, thank you for your answer. So yeah, it's definitely something very important that still has to be improved. Let's see if we have any other questions from the audience. Another question from Dr. Abhishek, actually. So ongoing treatments get disrupted during a humanitarian crisis. For example, for tuberculosis or cancer, which require chronic management, how do humanitarian organizations ensure continuity of this care, in addition to providing the care that the crisis demands? Very good question.
Yes, it's always a challenge, and then we tried, and that's quite interesting. I just think that the package of services, medical services offered in times of crisis, is getting more sophisticated through time. And then I remember when I started to do humanitarian aid work in war zones, that we basically will do only what is saving lives, physical life, and so therefore that would be the trauma. I'm an ER physician. That would stabilization of trauma patients, suturing, bringing them into the operating theater. And then as things has evolved, we have made huge effort to making sure to have the least disruption for chronic infectious diseases like tuberculosis or like AIDS. And in many places now we have contingency plan of what this happened in terms of giving people's treatment for several months instead of only a month at a time. And now we are hoping, for example, for HIV, that there's going to be the long-term IM treatment. We do hope that this is something that's going to be deployed, in war zones. So we have to make sure that technology that is available in the high-income country can be used as well in crisis zone, because that would make a huge difference in terms of adherence to treatment. And then one of the things that we've just seen recently, and it's happening right now as I'm talking to you, it's in Ukraine, where we've been doing different type of patient who's been evacuated to different country in the EU. But one of the things that has been done, and now they have, I think, transferred more than 1,500 children. It's about children who had cancer, mostly leukemia, but under treatment. And basically, they've been transferred in more than 30 different countries, and this is at that scale. I think it's a premiere at that scale. And this is not something people will have done, because when you think of Ukraine, you think of and this is where I was when I was in the Donbass, is people who had sustained shrapnel wounds, or I've I've been at the wrong place with bullets or whatever, penetrating trauma. But leukemia and follow-up of cancer was not on the top list. But St. Jude Hospital, I put a whole mechanism through that network of the cancer, I would say, association. And now the children are being transferred. And I think they're starting to do some adult as well. But we are way above 1,500 patients who have been able to continue their treatment. And so I think we're all evolving in terms of what needs to be addressed in a time of crisis, and then making sure that it's not because it's not a life-threatening issue now that it shouldn't be addressed. People know now that we have to address it and make sure there won't be disruption of treatment.
Yeah, it's great to hear that this is becoming considered more and more. So especially considering the shifting global burden of disease with chronic diseases. So thank you for your answer on that. So maybe we have time for one more question. There's one from Emmanuel. When providing aid to a community where heads of households receiving aid on behalf of the family is usually the men, how do we engage or empower women of the community and facilitate their needs, but without upsetting the existing power balance within that community?
Yeah, it depends. When you're in time of crisis, I think it's going to be hard to change the way the things are. On the other hand, you can possibly have what we do often is especially when it's nutrition, it's often the woman who's going to come and not the man. Men often come, but my experience, but I haven't experienced everything in life. But often when it's like about plastic shitting and goods for the house, it's going to be men, because they're going to come and they're going to need to carry the thing to a certain extent, because often women comes. But often when it's about nutrition and food, especially for children who are malnourished, this is where you can catch up back on women and then here. So you need to make sure that you can have programs that are complementary, and then eventually that will allow you to reach from I would say a same family, you will have access to the father or the mother. So and so therefore you will have a better understanding of what's going on. For me, what I think that I've been involved in the AIDS ecosystem for almost 3 decades now, and we are perfectly aware that it hasn't been perfect, and that it needs to be, I would say, massive improvement. But unless you and when you realize what the ecosystem of aid right now is very complex, with all agency, many layers. There's too many layers, too many players, and then often things get basically I would say paralyzed by the system. And so my message to you, you're going to be the new generation of global leaders, is do not accept a no for a no. And you're probably going to need to deconstruct some of the system we have made to make them more efficient. Because that, and then the process of decolonizing aid, it's probably will probably lead to decreasing the number of players and layers, and making sure that it's beneficiary or patient-centered, and based on their needs. And so this is something that a lot of people are I would say giving lip service, but they're not walking the talk of decolonization of aid. So it's in your hands. You need to do that, and you need to do that with conviction. otherwise nothing will happen.
Thank you very much for that advice and that important reminder. So maybe I'll have Sapna ask one last quick question. She has her hand up, and then we'll close the audience section.
Thank you so much for the opportunity to ask this question. So I'm Sapna Sudarangani. I'm one of the ID physicians here in Singapore, and thanks for this session. If it's okay, I'll ask two short questions that are kind of related to what we've been talking about. So there's climate change, there's extreme weather events, there's war that's still ongoing, a lot of inequity issues. And as you mentioned, decolonization of the humanitarian sector is a top priority. When you mentioned, building capacity, and that's been something that has been maybe not the focus of a humanitarian aid organization, do you think it's a funding strategy issue where not enough funds or resources are given to local staff? I know MSF does hire a considerable number of local staff, but is it more to pivot it to really focus on local capacity where possible without discounting the need for external healthcare workers to come in when it's a true crisis? But that was my question. Is it a funding, paradigm issue? And then I guess my last question to you was a more personal one, because you ended with that comment, is how do you remain hopeful for, this whole sector, given the challenges that are ongoing? And I'll pause there. Thank you.
Well, is it a funding paradigm? I think that I think there's more and more locally the competences to do things. So and yes, there is an issue of funding, and so I think it's going to be a process, and it's going to take a few years to happen, in a sense that there's the accountability process, and then people need to make sure the money is going where it's supposed to be, and blah blah blah. And then for some reason, people from here, we're pretty used to that because we go through that, and we basically were taught through those kind of legwork. So I think we're going to need to enable people to be able to take the funds and do the accountability, and then this accountability will be done in a way that is acceptable for the donors. But there's going to be I think some adjustment, because going over the white savior complex, it won't be a small feat, and then as well, donors country needs to be comforted in this new type of dynamic, and then so we need to find the right mechanisms, because if they're not satisfied, and if they think that the money is not followed through properly, and it's not giving, so I guess it's the result that will the proof is going to be in the pudding through the results. But yeah, for me, that's what it's a process that needs to be accompanied and that need to be helped through. And then the idea is that we probably become completely obsolete, but the reality is nobody as well will give money. We give a blank check without accountability. We have to be aware about that. So how do we make it and foster for process that is palatable and doable and adapted to the circumstances?
Thank you so much for that answer. So I think we will now close the session. So I would like to thank again Dr. Liu for participating in this conversation with us today. It was really insightful to hear your insights from generally the setup of humanitarian aid, from gender and humanitarian crisis, all your advice for the new generation of global health leaders and workers present here today to listen to you. So we really appreciate your time. Thank you very much, Prof. Howard, as well, for moderating the initial Q&A, and Vice Dean Liang Xu for introducing our speakers. Thank you to everyone for attending, and we hope to see you at the next two webinars of the Women in Global Health webinar series, which is organized alongside the University of Malaya. We'll send out details on those in the next few months. And have a nice evening or morning in the case of Dr. Liu, who's joining us from Montreal.
Thank you very much. Have a good day.